Okay, so I wanted to finish up the rest of chapter 25 and then add chapter 26, so we'll be done with adult. So going back to review a little bit, since we went through things fast, ventricular tachycardia, that is when we're going to have more than 3 PVCs in a row. We have a quick rate with this. It's about 150 to 250 beats per minute. We have that widened QRS. So in this, our patient can have a pulse or be pulseless. So if our patient is stable, meaning that they have a pulse, your treatment is going to be antiarrhythmics. Most commonly, we use amiodarone. Um, if your patient is pulseless or unstable, you want to do immediate defibrillation. Um, you're going to follow your ACLS algorithm. But for a BLS trained nurse, we are going to, check for a pulse. There's no pulse, start CPR. And then as soon as you can get a defibrillator in there, we want immediate defibrillation. I just wanted to add on this to remember we want minimal pauses during CPR. And you can be doing compressions while somebody is placing that defibrillator pads. Okay. Alrighty, so this is our ventricular tachycardia rhythm. Um, so you can see here we have more than 3 PVCs in a row. Okay. Um, so sometimes our patients, if they do still have a pulse, they can be aware that they have a sudden increase in their heart rate. But they'll commonly experience dyspnea, palpitations, and lightheadedness. Okay. So this could be one of your lethal rhythms that you would need to identify. But with this, it will tell you if there is a pulse or not for your patient in a test question scenario. Alrighty, moving on to ventricular fibrillation and asystole. So with VFib, we talked about how the ventricles are just kind of quivering. There's no organized motion. So it's a chaotic rhythm with no QRS. There will be no pulse, and we want to defibrillate ASAP like we would with the pulseless VTAC. So we want, we go in, see the VFib on the monitor. We will check our patient's pulse, start CPR immediately, and call for a defibrillator. Hopefully somebody's bringing that. We'll get, we want defibrillation as soon as possible. Okay, with this, your ACLS certified nurse is going to be going through the algorithm, the ACLS algorithm, giving epi and amiodarone. Okay, we want to remember that every minute without defibrillation with VFib, we are decreasing our chance of survival. Okay, with our patient in asystole, this is going to be a flat line. I want you to remember it does not have to be completely flat. There can be tiny little quivers in it, but it is not going to be big quivers like you would see with a VFib. Okay, so you may have some, a little bit of activity there, but it'll be very apparent if it's asystole. Okay, with the asystole, of course, check for a pulse. No pulse, start CPR. We cannot shock this. We cannot defibrillate. So we are going to be giving meds and high quality CPR while looking for our reversible causes. So we just want to remember with this, check for a pulse, start CPR, do not defibrillate asystole. Okay. Alrighty, so this top rhythm, we have the ventricular fibrillation or VFib. We want to check for a pulse. No pulse, start CPR. Call for help, get the defibrillator. Okay, quick defibrillation. The asystole, like with this example, it has the little quivers. but you don't have much going from that baseline. Okay, so this is going to be considered asystole. We walk in, see this on the monitor, we want to check for a pulse, start high quality CPR, yell for help. Okay. Alrighty, these are going to be some of our key medications that we use during arrhythmias for testing purposes. We don't need to know these for our test, well, except for the digoxin, but they're good things to know. So for that adenosine, this is going to work with AV nodal blocking. We are going to push this very fast. A lot of times we use what's called a stopcock. So we'll have the medication on one end that'll be placed on the patient's IV line. You'll push the medicine and flush it quickly right after, and sometimes we'll even raise their arm. So we're just trying to get it to the heart as quickly as possible. So this medication is going to be used for SVT. Amiodarone, that is the one that is most commonly used. This is going to be for AFib, A-flutter, ventricular rhythms. This can be either amiodarone pushes, so IV push, or it can be made into a continuous infusion. Our beta blockers and calcium channel blockers we are going to use for rate control, remembering to monitor our blood pressure and heart rate. The atropine we can use for symptomatic bradycardia, so your patient can still have a pulse, still be awake, they're just starting to get like hypotensive with their bradycardia. The digoxin, we are going to use that after we've checked their apical pulse for 1 full minute. We're going to use that for rate control. We will check therapeutic levels with digoxin, watching our potassium, magnesium, and calcium. One common toxicity thing that people will complain about is seeing like yellow halos around things. Our vasopressors, so our epinephrine, dopamine, norepinephrine, these are some of our ACLS drugs. We are going to monitor hemodynamics with those. Then our anticoagulants, so our warfarin, our Coumadin, we're going to be monitoring our INR for that. The DOACs, so we don't have, those are some of our newer drugs like the Xarelto. I can never think the other name, but you don't need to know those for your test. You can look them up to know them for NCLEX, but we do not have routine monitoring for these. Okay, we want to do renal dosing if appropriate. Okay, so our patients that are needing a pacemaker. So we can temporarily pace somebody. Temporarily, we can do this either transcutaneously or transvenously, or epicardial, so after, if in a post-op situation. But most often, you would see transcutaneous pacing. So a lot of our defibrillators can also act as a transcutaneous pacer. So that will just be, they can pace through the pads that are on there until we can get our patient to get a permanent pacemaker placed. Okay. Our permanent pacemakers, that's either going to be a single lead going into the right atrium or the right ventricle, or it can be a dual chamber going into both, but we are going to use pacing for symptomatic bradycardia, if somebody's in a 3rd degree block, some tachycardic rhythms, we can overpace them, okay? Or if we have a pacemaker, our patient already has one and is failing to capture, we might need to pace them temporarily. There are leadless pacemakers now. They have like a 8 to 12 year battery life. So the leads, they're really cool to actually watch placed. A lot of the times that I've seen them done was to go in and replace leads. So those leads can sometimes come detached. So whenever we have a patient with a pacemaker on tele, we can see their spikes that they're either atrial paced, ventricular paced, or they can be both. They can be AV paced. Okay. Gonna go back for a second. Oh, no, this slide's good. Okay, sorry. All right, so our nursing care and teaching for our pacemaker placements, this is what I want you to know more about rather than your different types of pacemakers. So our teaching for our patient, we want to monitor rhythm, monitor their apical pulse, report any rates below their set point. A lot of these are set at like 60, 70, okay? We want to do good incision care, keeping it clean and dry, monitoring for any infection, following activity limitations. They are advised not to raise their arms above their shoulders for I think 2 weeks it is. We want to avoid any heavy lifting as well. We want to, usually they'll get a card that says what the make and model of their pacemaker is, if it's MRI compatible. And we want to encourage people to carry that ID card, okay? And then we want to, going along with the magnet, or the MRIs, avoiding magnets or metal detectors, okay? Things that we want to teach our patient to report is any chest pain, dizziness, or syncope, palpitations, and sometimes patients can report a lot of hiccuping after placement and feeling like their chest is kind of twitching. Okay. Alrighty, I think that's all I want to say about that. The last thing that I had written down with that is it used to be like an old wives' tale that if you had a pacemaker, you couldn't be around a microwave. Microwaves are completely safe for people with pacemakers, and most airport security is safe for brief passage, okay? But we want to teach our patients that any chest pain, dizziness, syncope could be an indication that their pacemaker is malfunctioning and they're having an arrhythmia, and the hiccups and twitching can be from when lead placement or leads are displaced. Okay, so defibrillation and synchronized cardioversion. What I want you to know is that you are going to defibrillate pulseless VT and VFib. This can be an unsynchronized high energy shock. We want to do this as quickly as possible to get our heart back into a regular rhythm. Our synchronized cardioversion, this can be for our ventricular tachycardia with a pulse, AFib, A-flutter, or SVT. What I want you to know about the cardioversion is that this is our treatment of choice whenever our patients are symptomatic. Okay, so we want for them to be symptomatic, and this is an elective procedure. We want to usually provide some kind of sedation though, because you're being shocked, that's gonna, hurt. So if possible, we want to sedate. So safety issues, we want to have proper pad placement on our patient. We want the conductive medium, we want to have it flush against their chest, clearing any hair if we need to. We want to make sure that our patient is cleared, that all staff are not touching the bed before we deliver the shock. Okay, I think that's all that I wanted to say about that. Okay, Alrighty, so AEDs and our implantable ICDs. Our AEDs are the things that we usually see out in public. Those are our automatic, goes through the motions. We're not pushing any buttons or dialing, or well, we're pushing a button to turn it on, but we're not, picking settings. Okay, so our AED is going to analyze our rhythm for us and advise to deliver shock if it does detect a shockable rhythm. Okay, these are your things that are out in public. One thing that I told my group that I was with at clinicals today, we want to make sure that our pads are plugged in and our machine is turned on for it to work. Okay. So our ICDs, these are going to be implanted in your patient, much like a pacemaker. It's going to detect either VTAC or VFib and deliver a shock. Okay. So what we want to teach our patients is that they need to replace their batteries in their ICD. That needs to happen, and then we need to educate our patient that they can feel the shock whenever the ICD fires, and that if they do feel like they're shocked, they need to give their physician a call. Okay. Alrighty, so our nursing care plan for arrhythmias, we're going to have a diagnosis of increased cardiac output, anxiety. We want to monitor our patient's apical heart rate, monitor their blood pressure, make sure we're listening to lung sounds, monitoring urine output, our patient's mentation, and assisting with ADLs to conserve energy and limit oxygen demand. Okay. Our older adults will have a higher toxicity risk. So if they are taking drugs like digoxin, we want to be sure to monitor those closely. And we want to teach our patient to avoid any vasovagal maneuvers, so avoid straining, and teaching them to check their pulse with any beta blocker or digoxin use. Okay, we don't want to skip any of those doses, so if they will be traveling for long periods of time, having a plan for their medication. Alrighty, so our practice questions: a patient with new onset irregular rhythm with no visible P waves reports palpitation. Okay, so our priority action: this patient sounds like they're stable. We know that there's no P waves. It's an irregular rhythm, so I would guess, without saying anything, that that is going to be AFib based on the description. Our question's not telling us that they are unstable, and so I would go ahead and obtain a 12-lead EKG. Okay. Alrighty, a telestrip shows complete heart block with a ventricular escape rhythm of 30. We didn't talk too much about heart blocks, but we see that our heart rate is, we're at 30. Knowing a complete heart block, we know that we can't sustain this. So I would start transcutaneous pacing. Okay. Alrighty, and our third question, a patient in pulseless ventricular tachycardia collapses on the unit. Which action is correct? So it is, we can start CPR and then immediate defibrillation. Alrighty, moving on to chapter 26. So this is going to be for our patients with heart failure. Alrighty, so definition of heart failure is a clinical syndrome of impaired ventricular filling and or ejection. So this is going to decrease our perfusion. Common symptoms with these patients is going to be dyspnea, fatigue, and they can have fluid overload. Major causes of this is going to be coronary artery disease, myocardial infarction, cardiomyopathy, valvular disease, hypertension, and in our older adult population, ischemia. Okay, we can have acute exacerbations of this, but it is a progressive disease. Alrighty, our population is pretty heavily affected with this. We have about 6.2 million people in the United States with around 1 million new cases each year. We find this more in our Black African American women, and it is one of the leading admission causes of older adults in the U.S. Okay, so anytime we have that decreased perfusion, we want to monitor our urine output, mental status, and just take a look at our patient's skin too. That can tell us a lot about how they're perfusing. Okay, so we have two types of dysfunction, systolic dysfunction and diastolic. Our systolic is going to be dealing with impaired contractility, and diastolic is going to be the impaired relaxation, so our filling phase. Excuse me, we can have a mix of the two as well. What I want you to get from this is that with the chamber dilation, with this, as our heart starts to remodel, trying to compensate, that we can compensate well at first, but it's later going to lead to failure down the road. Okay, so our compensation helps up front, but our increased oxygen demand is going to worsen our heart failure. Okay, so what I do want you to know for your test is the difference between right-sided heart failure and left-sided heart failure. Okay, our right-sided is often going to be secondary to left-sided heart failure, but we're going to have more of our systemic venous congestion. So we're going to see the JVD, hepatosplenomegaly, ascites. So we're going to look at their abdomen. I cannot talk. Their abdomen is going to grow on us. Peripheral edema, they can have some GI upset and anorexia, weight gain, and they will have nocturia. On our left-sided heart failure, that's going to be more of our left side lungs. Okay, that's how I like to remember that. So as we back up into the left atrium, our pulmonary veins and our lungs are going to back up, increasing our pulmonary pressure. Okay, so we are with this increase in pressure, we're going to have more edema, leading to impaired gas exchange. So symptoms of this is going to be dyspnea on exertion, orthopnea, I can never say this P word, the paroxysmal nocturnal dyspnea, so where they're going to be sleeping propped up. They can have a dry cough. You can auscultate crackles and wheezes. They may have cyanosis, tachypnea, and tachycardia. Okay, common causes of this is going to be hypertension, and MI, cardiomyopathy, aortic or mitral disease, car articulation, and myocarditis. Okay, so think left, more of our lung issues, and our left-sided heart failure usually leads to our right. Okay, so the failure of one over time is leading to the failure of the other. Alrighty, so pulmonary edema. This is going to be a rapid increase in our pulmonary venous pressures, leading to severe hypoxemia. Okay, so as that fluid starts to build up around our alveoli, we're going to have hypoxemia. So the classic sign of this is going to be pink frothy sputum. Whenever your patient, if they ever start to cough this up, we are at a medical emergency. Okay, they will become very restless. They may express like a feeling of impending doom. You're going to see tachypnea, accessory muscle use, so the retractions in their neck, may have rib retractions. You can auscultate crackles and wheezes. May have clammy, pale skin. So just know that we are at a medical emergency here, okay? This is a serious complication of heart failure. But what we want to do as the nurse is position this person upright. Usually we want to put like a non-rebreather mask on them to deliver the oxygen. We're going to be calling for help. This is a situation where I'd call a rapid. And they will usually treat with diuretics and medications to decrease our afterload. So that could be vasodilators like our nitro, and then they used to use morphine, but that also can decrease your preload. But it does a good job with the anxiety. So what we want to do with these patients is be monitoring their EKG, checking their pulse ox, looking at their hemodynamics, okay? But I want you to recognize that when you see that pink frothy sputum, we are in an emergency situation. Okay, so our heart failure diagnostics. What I want you to know from these mainly is that our BNP or pro-BNP, that is going to be a marker that is going to tell us that we're in volume overload. Okay, so whenever that is increased, we're in volume overload. Imaging wise, we use an echo to find out their ejection fraction. But those are going to be our two main diagnostic testing for our heart failure. Our normal ejection fraction is around 55 to 70. So that's going to be reduced in our heart failure patient. Okay. Non-invasive measures, we want to treat our underlying causes, if appropriate, cardiac rehab. But we want to titrate our patients' ABG, looking for that hypoxemia on the ABG. Looking for hypoxia with their SpO2. We want to teach them about their diet, their fluid restrictions, to call their provider if they're having a 2 to 3 pound weight gain over a day. But mainly teaching them symptom recognition and just their overall importance on staying healthy. Alrighty, so we will talk more about our medications in class, but our medications that I want you to focus on for testing purpose is our ACE inhibitors. I would know what it does. A lot of people will stop taking it because of the cough. Okay, so we want to teach them to call us if this cough is intolerable. Do not stop without calling first. Okay. Next one I want you to focus on is your beta blockers. Okay, we want to teach our patient to check their pulse, check their blood pressure. With these, educate on orthostatic hypotension, so change position slowly, stand up slowly. Okay, our loop diuretics, our furosemide, and then we also have our thiazide and our spironolactone. We want to monitor our potassium with these, our renal function, and teach them to take these in the morning. Okay, you do not want to take these at night. And then our digoxin we are using for rate control. We want to monitor for toxicity. Again, we want to take our digoxin around the same time every day, not skipping doses. If we do skip a dose, we do not want to make up that dose. And then if you are in a toxicity situation, you can see those yellowed halos. Okay. Alrighty. I'm not going to talk much about the biventricular pacing, the ICD, or we have these wearable defibrillators called life packs. If you're in that specialty, you're going to get more training on those, as well as the LVADs, okay? These are just, you have more support out there if you need it, okay? Alrighty, so subjectively, we're walking into the room. What kind of assessment are we going to do? We're going to be looking at our patient. What is their pattern of breathing? Okay, when we look at them, are they edematous? Are they complaining of weight gain? Are they having any nocturia that they're complaining of? Chest pain, palpitations, assessing for fatigue. Are they experiencing any anorexia, okay, any cognitive changes? We want to take a look at their vital signs, assess for JVD, auscultate their lung sounds, okay, looking at their abdominal girth, and then, of course, checking their skin. Do they look tight and shiny? Okay. Alrighty. These are some of your nursing diagnosis that you can look for. So if you have a patient that you did your care plan on from clinical and they were in heart failure, there are some diagnosis for you. Okay. Alrighty, again, we want to educate to call for a 2 to 3 pound weight gain over 1 to 2 days. If they are having an increase in difficulty breathing, we want them to call, okay? So educating them on daily weights, so using the same scale, weighing, wearing the same stuff, keeping a log of these things, and then teaching them good diet skills, label reading. Okay. Did I skip one? Well, it won't let me go back. Okay. So again, this slide is talking about your pulmonary edema being a medical emergency. Go ahead and call a rapid response. Sit your patient upright, if possible, having their legs in a dependent position. Apply oxygen, and then we want to ensure patent IV access. Those are things that we can do while we're waiting for everyone to get there. Okay. We want our patient to be on continuous monitoring. They'll usually call and obtain an ABG, okay, get a chest x-ray, have a 12-lead EKG. Alrighty, we're not going to talk too much about cardiac transplant just because it is so specialized, but we have kind of two ways that we can do this. We can replace the entire heart, or we can add the donor heart, keeping part of the old heart in place. So the patient's original heart can either be removed completely or kind of added to with the donor heart. Okay, they will be on immunosuppression, so we want to teach good infection prevention, good hand hygiene. In my experience, so they usually do like a triple drug immunosuppression. In my experience, I've used a lot of Tacro, and then I can never say this one, but it's also called Cellcept. So a lot of Tacro, Cellcept, and prednisone. At first, they're going to be on high doses of prednisone, but that will eventually taper off. Okay, we want to educate our families on. Well, in the hospital, we can recognize more of the acute rejection, but educating our family on kind of the long-term rejection symptoms, preventing infection, okay? And at post-op, immediately we're going to be looking at fluid balances, electrolytes, our patient's oxygenation, and they will do the cardiac rehab as well. Okay, so kind of the key points of all this are heart failure is going to be an impaired filling or ejection that leads to a decreased perfusion. It is often progressive, and it can have acute exacerbations. Left-sided heart failures, you can expect to have lung issues, so our pulmonary congestion. Our right-sided heart failure is going to be more systemic. Remember, usually we have start with the left-sided heart failure that progresses to the right-sided heart failure. Our pulmonary edema is a life-threatening emergency. We want to sit them up and get oxygen on them, okay? Alrighty, our practice questions here. A patient with history of heart failure arrives with severe dyspnea, pink frothy sputum. So that right there is telling me we're in a bad situation. I'm going to call for extra help. Respirations are 32 a minute, BP 170/96, SpO2 is at 86% on 2 liters. What action should the nurse take first? Place your patient in a high Fowler's position and apply a non-rebreather mask. Alrighty. Question 2, a patient with chronic heart failure is taking furosemide and digoxin. Today they report nausea and seeing yellow halos. Their potassium is at 3. What's the best nursing action? So I would go ahead and hold that dose and notify the provider, okay, and anticipate that they're going to draw a digoxin level, checking for toxicity. Alrighty, so next question. Which statement by a patient with heart failure indicates correct understanding of home care? So A, B, and D, you do not want to use a lot of salt substitutes while taking spironolactone, because a lot of salt substitutes, like your Mrs. Dash, things like that, contain potassium. So we know that our spironolactone is potassium sparing. So with that, we can get our potassium levels too high, okay? And then we don't want to take all of our blood pressures together unless that is what our healthcare provider has told us.